So when we decided on COVID-19 as a subject for this webcast, the first person that came to mind as a speaker was Roger Seheult, co-founder of MedCram.com. MedCram.com is a leader in producing instructional videos for medical professionals and students. They provided videos to a variety of medical schools, hospitals, universities, and their YouTube channel has received over 50 million video views. Over the last 2 months, MedCram's coronavirus pandemic updates have offered some of the most evidence-based information available, most up-to-date that you could find online. So it's with my great pleasure I'd like to welcome Roger Seheult to our webcast today. Dr. Seheult is a pulmonary critical care and sleep specialist in Redlands, California. He's a pulmonologist and sleep specialist at Beaver Medical Group, where he serves on their board. He has dual academic appointments as an assistant clinical professor of medicine and physician assistant sciences at the Loma Linda University School of Medicine and Allied Health Professions, respectively. He is also an associate clinical professor at the University of California, Riverside School of Medicine, as well as the medical director for the Crafton Hills College School of Respiratory Therapy. Finally, Dr. Seheult is board certified in internal medicine, pulmonary diseases, critical care medicine, and sleep medicine. He's also a co-founder of MedCram. And speaking about MedCram, we also have with us today Kyle Aldred. Kyle is a physician assistant who has practiced in both family medicine and urgent care. He's director and co-founder of MedCram.com and is also conference director at wildernessmedicine.com. I'd like to welcome both of you to today's webcast.
All right. Thank you so much, Walter. It's a pleasure to be here. So what we wanted to do was update on the clinical updates so far and the lessons learned thus far with COVID-19. What I wanted to do was briefly get into the pathophysiology and the epidemiology. And what I've got here is a very short 7-minute video on really how does coronavirus infect human cells. You know, that's really important because later on we're going to be talking about how to target these very specific areas in the pathophysiology and the epidemiology of COVID-19. So let's watch this for about 7 or 8 minutes to give you some introduction on coronavirus.
But you should be aware that the outside of this cell is something called a lipid bilayer. And actually, the nucleus is a double layer of a bilayer, which we don't have to worry about. But if you were to look at this very carefully, there would be a hydrophilic layer on the bottom and the top, and in the middle it would be lipophilic. So it's known as a lipid bilayer. Well, guess what? This virus also is made up of a lipid bilayer. And it has a hydrophilic side on the outside, and it has a lipophilic on the inside. So it looks very similar. This is the reason why you can destroy viruses with detergents. Detergents can break that up. This virus has proteins. Specifically, we'll talk about the coronavirus, since that's what we are concerned about. And there are proteins that are embedded in this lipid bilayer. And this protein that I'm drawing here right now is called the S protein, and it goes all the way through the lipid membrane. Now, there are other proteins in there. For instance, there are M proteins, there are also E proteins, and they all have their specific function of structure to keep this virus intact. And then what's inside is the genome. It's a tightly packed, very large RNA genome, and it's bound with N proteins. So there's N proteins all through here binding the RNA molecule. So you've got S proteins that help bind at the end here. They are going to dock with cells. You have an E protein, which is a membrane inside of the bilipid membrane layer. You have a M protein, which is a protein also in the membrane. You have N proteins, which help bind it. So all of these are proteins that have to be coated by something. Then, of course, you have the RNA. And that's key here, is understanding that coronavirus is an RNA virus. So in this situation, we have a receptor on the surface of the human cell here, which is known as the ACE2 receptor, or ACE2 protein. This S protein fits perfectly into that ACE2 and binds to it. And so when one of these comes and binds, what you get at that point looks something similar to this. And you can see here that all of the viral contents comes into the cytoplasm. Well, let's redraw this RNA molecule from the virus, and you'll start to see something very astounding. That's right. It's an RNA, and it has a 5' cap, and it has a poly-A tail, just exactly as we have our messenger RNA ready for translation. Also notice that the cell incorporates the viral envelope as part of its outer membrane. And so as a result of that, these S proteins that were there initially now become part of the cellular membrane, marking it potentially for cellular destruction. Meanwhile, our ribosomes jump right on to this viral genome and start to march down the RNA. Now, this is what's known as a positive sense RNA. And what does that mean? It means that when the ribosomes come on to this RNA and they start to go from the 5' down to the 3' end, it's going to make a protein. And the protein that it makes is something called a RNA-dependent RNA polymerase. And so here it starts to make this protein. And there it is. And that's abbreviated RNA-dependent RNA polymerase, otherwise known as a replicase. And what this means is that this protein that is coded for by this mRNA will now take this positive stranded RNA, it's only one strand, and it will now march from the other end, because it reads from the 3' end, and it will start to march in this direction, going along the RNA, and make another RNA that is complementary to the previous one. Here, this will be the 5' end. This will be the 3' end. And of course, this is going to be complementary to the original, so this will be a negative stranded RNA. But guess what? This RDRP is then going to come onto this one and start over on this side, and it's going to read down this way. And the product of that is going to be the original viral genome. And so you can see here that this RNA replicase is going to be making more and more RNAs so that they can package these into new virons that this cell is going to be making so it can make more virus. And now the part that really blows me away, when this RNA-dependent RNA polymerase starts to go back on again, and it starts to do this, sometimes it doesn't reach right at the end. Sometimes it reaches from here and will only copy this part. And so you'll get a shorter RNA. Or it'll come from this side here and it'll get a shorter RNA. Well, when you get these shorter RNAs, these are known as subgenomic RNAs, or sgRNAs. And some of them are positive, and of course some of them are going to be negative because they're complementary. And this viral RNA-dependent RNA polymerase will just make more sgRNAs or negative sgRNAs. Well, guess what? These smaller ones also code for the smaller proteins on the virus. And so all of these RNAs can be seen and read by ribosomes that the host is donating to the cause. See, it hijacks your cell. And so these smaller proteins can be, for instance, M proteins, which the virus needs to be made for it. And it can also be E proteins. And so the virus comes into the cell, and the key here that you have to understand is it gives up its RNA into the cell, and it's ready-made for the ribosomes of the cell to make this protein right here called RNA-dependent RNA polymerase. Anything that ends in an ACE is an enzyme, and it tells you what it does. It's an RNA-dependent, which means it reads RNA, and it makes more RNA. That's what a polymerase is. It puts the little nucleotides together into a long chain with little beads. And that information helps tell the ribosomes, instead of making the proteins that your cell needs to make, it makes the protein that the virus wants to make, and it does it in this very clever way. So the question is, how can we interrupt this? Because what happens after this is some of these ribosomes are floating around in the cytoplasm, but some of these ribosomes are actually attached to a membrane which is contiguous with this outer membrane. And so they can insert all of those proteins just like they want, and then the reverse of what happened here at the beginning occurs, where these things bud off and little viruses get packaged and they go off. That's how one viron is able to go into one human being and millions of viruses come out. It's because it hijacks the molecular biology of the cells. And it happens to be that these ACE2 receptors are, generally speaking, in the lower portion of your respiratory tract. With all of these cellular outer membranes, with all of these foreign proteins, you know the immune system is going to start attacking these cells. And that's what happens with these lower respiratory cells. They become inflamed, they leak fluid, and that's what causes the pneumonia and the respiratory failure.
So you can see very clearly that it's an involved process, and there's many points along that way that the virus can be interrupted, and that's what we're going to be talking about in the latter portion of today's presentation, is what is the treatment mechanisms. So the other thing that we have found very interesting is that the ACE2 receptor is not the only receptor that the virus attacks. It also attacks the CD147 in the T lymphocytes as well. And almost uniformly in the patients that I take care of, they almost always have very low lymphocyte counts, which is a concerning thing because this is part of the immune system and helps them mount a response against COVID-19. But the other thing that's interesting and you may not know is that not only is ACE2 the receptor for SARS-CoV-2 and being in the lungs, it's also found extensively through the endothelium. And that's important because, as you can see here at the bottom, angiotensin-converting enzyme confers endothelial protection and attenuates atherosclerosis, not only atherosclerosis, but also oxidative stress, etc. And so we don't have to go through this in detail, but many of you know that angiotensin, the renin-angiotensin system, is implicated with this. We know that angiotensin goes to angiotensin 1 through renin, and that goes to angiotensin 2. And that we're going to be talking about angiotensin 2 later on. So keep that in mind. Remember that ACE inhibitors block angiotensin 1 to go into angiotensin 2, but what you may not know is that angiotensin 2, which is a vasoconstrictor, very potent vasoconstrictor, is metabolized by ACE2. Yes, ACE2, the very same target of SARS-CoV-2, and it metabolizes angiotensin 2, which is a potent vasoconstrictor, to angiotensin 1,7, which is a vasodilator. Now, in situations where ACE2 is not able to do that, angiotensin 2 levels increase significantly, and then they are metabolized not by ACE2, but the receptor for angiotensin 2 is the angiotensin receptor. And this causes, as you can see here, the opposite: vasoconstriction, ARDS, fluid leakage. And you can see that what we're seeing in COVID-19 is very reminiscent of this pathway here of the angiotensin 2 going to ACE2, but ACE2 not being able to metabolize it because the virus is taking ACE2 out of commission. And then the angiotensin receptor is binding with angiotensin 2 and causing vasoconstriction. So let's talk a little bit about the course of the disease. You know, very early on in Wuhan, we were getting information about how this disease went. I like to call it phase 1, 2, and 3. Phase 1 being prior to infection. Phase 2 is during the incubation period and while the symptoms are building. And then finally, in phase 3, when they're admitted to the hospital. And many times, this is a very downward course, very quickly. And we've seen that in the hospital. Let's talk about hospitalization. There was a recent article that was published in JAMA looking at from March 1st to April 4th. And they looked at people being admitted in the New York City area. 100% of these people being admitted, 60% male, 40% female. So we do see a male predilection to this. Interestingly, only 30% of them had a fever, 31% fever, 14% of them had to go to the intensive care unit. In the intensive care unit, the median age there was 68 years of age, 66% of them were male, and 12% of them needed mechanical ventilation overall, as you can see. What is very concerning, though, is of those people admitted to the hospital, 21% of them had died, basically, had a 21% mortality. Those going to the intensive care or needing mechanical ventilation, 88% of them. And you can see that there's a very, very high correlation with those people needing ventilation and those dying, which should not surprise us. If we look at those people by age, if greater than 65 years of age on a ventilator, mortality was 97%. That's an extremely high percentage. All right, let's look at the other side of it. Not those that are admitted to the hospital, but those that are out in the community. Phase 2, we would like to call it. Recent studies there that show, at least in Southern California, out of USC, that doing 863 random tests showed that 4.1% of those that they tested were infected based on the fact that they had antibodies. And this correlated with anywhere between 22 and 55 times higher the number that they thought they had based on confirmed tests. And so what we're really seeing here is that we're seeing a small tip of the iceberg in terms of people who have symptoms, and then maybe about 20% of those are needing to go to the hospital. Of those, 22% of those have a mortality rate, and then of those needing mechanical ventilation, 88% die. So let's talk a little bit about the course of COVID-19. As we were mentioning, again, population, infection. Phase 2 are those people that are symptomatic, either at home or needing to go to the hospital. And I say here, 80% of those have symptoms but don't need to go to the hospital. 20% of those do need to go to the hospital. They have shortness of breath. We'll talk about the criteria for hospitalization. And then you enter phase 3, and this is where we're doing everything we possibly can to prevent these people from dying, including putting them on ventilators to support their breathing. But let's talk about the 80%. 80% of those don't need to go to the hospital, and the reason for that is probably because of their immune system. As you can see, the immune system is very complicated. There's an innate and an adaptive immune system. The cells that are particularly important we're finding out here are the natural killer cells and the monocytes for that innate immune system coverage. And that's important because there's been a number of papers that have come out of centers of excellence in Thailand that have looked at SARS-CoV-2 in relation to the previous coronaviruses. The previous coronaviruses being MERS-2 back in 2012 and the original SARS back in 2002. And so they looked at those viruses and they made predictions about what they would see here with COVID-19, and a lot of those predictions have come true. So let's look real quickly and see what the major points were out of this major review paper. Number one, they found that there was increased neutrophils and decreased lymphocytes. That's going to be important as we talk later on because neutrophils give a lot of oxidative burst. We're going to find out that oxidation is the real enemy here with COVID-19. NADPH oxidase is the enzyme in neutrophils, which causes oxygen to be turned into superoxide, and that actually is how neutrophils kill what they ingest. But in addition to that, we saw decreased lymphocytes. Lymphocytes are very important in terms of the immune response. And we saw that when there was increased neutrophils and decreased lymphocytes, that increased mortality. We know that the innate immune system is the target of SARS and MERS, and that it actually can hamper that. And that's why we may be seeing patients coming to the hospital needing help. Only 30% of them are having a fever. There may be uncontrolled viral replication. We see that there is a reduction in the adaptive immune system as well, T cells. There is a suppressed immune response. We're finding that out very clearly, that some of the proteins in coronavirus are actually suppressing the immune system, and that's what ivermectin is hopefully trying to be able to do. We also saw that there are antibodies that are being made, and those antibodies have been shown to prevent reinfection in some patients. So I think it sums it up on this article at the very bottom. It says, these facts strongly indicate that the innate immune response is a critical factor for disease outcome. And that kind of leads us to what a lot of people have been talking about, the BCG vaccine. The BCG vaccine stimulates the adaptive immune response because it's a vaccine. You're looking for an antibody response against tuberculosis. But what they found is that there is a spillover when the adaptive immune response is activated. There's an innate immune response which also is activated as well. And that, of course, is very important against the coronavirus. So you can see here that this adaptive immune response, like natural killer cells, the adaptive immune response, when it is activated, there's a spillover and the innate immune system is also activated. This is important because what they're noticing with people who have the BCG vaccine in countries, there's an improved response, it seems, maybe an association, but there's definitely an improved response. If you look at this map here, you'll see that those in orange are countries that have never given the BCG vaccine. Countries like Canada, like the United States, notably Italy. Although countries that are in yellow have have generally been giving the BCG vaccine. And you can see that there is quite a lot of countries in that color. The purple countries are countries that used to give the BCG vaccine, but they're not giving them anymore. There was a study that was done looking at the mortality rates and the incidence in these countries. And this was published by Dr. Ashish Kamat at MD Anderson in Houston, Texas. And he says, while we expected to see a protective effect of BCG, the magnitude of the difference, almost tenfold, and incidence and mortality between the countries without a BCG vaccination program was pleasantly surprising. So tenfold difference. The question is this an association or is this causation? Well, they're looking at this now, but clearly the innate immune system is very important in the COVID-19 epidemic. So let's briefly take a pause here. We've talked about the pathophysiology. We've talked about the epidemiology. We've talked about immunity. We see here that the death rates, those are people that have been admitted to the hospital and those that are not admitted to the hospital. We do see that immunity may play a large factor in determining who survives. So I want to unpack this, and what we want to do next is I want to introduce the other co-founder of MedCram.com, Kyle Allred, who's going to give us some questions. I'd like to take some questions based on the presentation so far. We're not done yet. We're going to go into diagnosis and treatment. But Kyle, maybe you can join us.
Okay. Roger, can you hear me all right?
Yes.
Here we go with the first question. So it's Peter from Melbourne, Florida, wants to know if COVID-19 is causing a large increase in ROS and oxidative stress, does that imply that there is damage being done to the nuclear DNA and the virus is carcinogenic?
Yeah, that's an interesting question. There's many diseases that we know increase reactive oxygen species, like cardiovascular disease and things of that nature. I don't know if we know about any cancers that are associated with that. However, we do have evidence that certain dietary things can cause cardiovascular disease and also are associated with cancers. But at this point, of course, it's way too early to tell. And of course, reactive oxygen species is a wide spectrum. There can be a small amount and there can be a large amount. So I think at this time, we don't really know.
Okay. Next question is from Sharon from Newmarket, Alabama. Previous comorbidity concerns with NSAIDs in SARS-CoV-2. Are there updated therapeutic prophylaxis risk-benefit considerations related to latest thrombosis research and per Dr. Seheult's patient observations of D-dimer levels?
The first part of that question, Kyle, was that non-steroidals, I heard you say?
Yep, non-steroidals. Okay.
So non-steroidals are tricky because non-steroidals, we know, decrease platelet adhesion, and they also are a bit of an anticoagulant, so you can bleed more. But we also know that there are certain NSAIDs that have a direct antiviral effect, specifically on influenza and even the SARS-1 virus, the original SARS virus. The problem is, though, is that these NSAIDs can also negate the body's febrile response, which has also been shown to be beneficial. So it's really a mixed bag at this point. I know there was some press on this because the French health minister initially had said that there were some negative associations with patients who had come in on NSAIDs, but they've later retracted that, and the WHO has as well. We really don't have any very good studies at this point, and I haven't seen any kind of patterns in my practice. What we've done in our hospital is, if we are going to treat a fever, we'll do so with Tylenol rather than NSAIDs. But I can also tell you there that we've become more conservative with our use of Tylenol, especially given the fact that we know that a fever can be beneficial, and also because a lot of our patients have elevated liver enzymes as part of this process.
Excellent. You have another question, Dr. Seheult?
Sure, yeah, we'll take one more and then we'll move.
Okay, so this is from a paramedic, this is from Kim, and she has a question about whether CPAP or BiPAP would be suitable treatment for these patients if they are conscious.
Yeah, so if they're conscious, that's exactly the point, is you want to make sure you have mental cognizance before you put these on, because if they can't protect your airway, they can have a lot of problems. So I guess the only reason why I would say you could use CPAP or BiPAP at home theoretically is to avoid hospitalization. But I think at that point, if you are needing to use BiPAP or CPAP, that's the point that you need to go to the hospital. If you have shortness of breath and you're having a difficult time breathing, it would be better for you to be monitored and seen at the hospital and getting BiPAP and CPAP than trying to do this at home.
Excellent. Well, I think you can go ahead and move on, and we'll take some more questions after your next segment.
Good. So this next segment is pretty short. It's talking about diagnosis. And specifically, what we're going to talk about here is the two basic tests for the diagnosis is the PCR and the antibody test. And we're going to watch a brief video on those descriptions.
I wanted to talk a little bit about testing. And again, I want to review, there's different types of testing that's going on. Up to this point, we've looked at reverse transcriptase PCR. And here we're looking at the RNA of the virus itself. This is usually done by a nasal swab. And if it's positive, it tells you that you are infected. And if it goes from positive to negative, generally speaking, what you're trying to find out is whether or not you're still infective. Now, this is very different than antibody testing. So with antibodies, you have an antigen-presenting cell that has eaten an infected cell and is presenting a portion of the virus on its surface that connects up with a T cell. And once that connection is made, there are cytokines which induce that T cell to do a number of things. Number one, the first possibility are memory cells. Number two are cytotoxic T cells. And number three are B cells that turn into plasma cells, and they create things called antibodies. And these antibodies go out and attack the virus. So this is different. We're not looking for RNA of the virus. We are looking for proteins, or specifically antibodies. This is not done with a nasal swab, but it's done with a finger prick. And what this tells you is whether or not you have IgG or IgM. IgM and IgG usually come up maybe around 6 to 7 days, generally speaking, after the beginning of an infection. And they both sort of come up, but the IgM will go away, and the IgG will be the only one that remains usually. And so IgM is usually seen in acute, and IgG is chronic. One of the things you should understand is just because you have the presence of antibodies, it doesn't mean that you would be negative on the infective state. So it's possible to be both positive on the reverse transcriptase PCR and also be positive on the antibody testing. And that would simply mean that your body has made antibodies against the virus, but you still have the virus and you're still infective.
Okay, so those are the two basic types of testing. The other thing that we're looking at in terms of that in the hospital is a lot of these biomarkers. So CRP, ferritin, D-dimer, LDH, CPK, and lymphocytes. If we have a question about somebody who's coming into the hospital and we haven't gotten the test back, these often tell us whether or not this patient is a COVID-19 patient or not, because we can simply tell by the ferritin, the D-dimer, the LDH. If these things are very high, there's very little else that these patients could have that would do this. And so I found these to be very, very helpful. It doesn't mean if it's negative that they don't have it, but it's another piece of information that you can have before you get the final COVID test back. Also helps in terms of whether or not you might think the patient may have a false negative test. If this patient is on the ventilator with super high CRPs, ferritin, D-dimer, and they have infiltrates and their test comes back negative, that might be one that you might want to recheck again. Of course, this is what the CT would look like. A point, though, is that whereas in China, they did a lot of CT scans to make diagnoses because that was the fastest way for them to do it. Here in the United States, the turnaround time in terms of what they have to do to clean the machine, clean the room before the next patient comes in is prohibitory to doing a lot of CT scanning. So make sure that you do CT scanning on a very important basis to make sure that it would change your management. So we'll stop there in terms of diagnosis. I know sometimes there's a lot of questions on that. Kyle, let's see if there's any questions on the diagnosis.
So not necessarily specific to diagnosis, but we have a viewer from Pakistan that wants to know how COVID-19 is related to stroke and thrombosis. And I know you talk a lot about that in this presentation and other videos on our site, but could you sum that up with a Cliff Notes version of that?
Excellent question. So we don't know exactly how it's happening, but we're definitely seeing an association. I mean, 30, 40-year-olds in New York are presenting to the hospital with strokes and no other symptoms, and then they turn out to be COVID positive. Is that an association? It's hard to say for sure, because there's so many people now that have COVID-19, and there's a lot of people that have strokes, but you really don't see that in 30 and 40-year-olds, generally speaking. One of the theories is that this being an endothelial cell disease, because of the fact that there's ACE2 receptors on the endothelial cells, what could happen is inflammation of those endothelial cells will cause a release of coagulation factors. We're going to talk about that coming up, but basically we will show you that there are releases of factor 8, von Willebrand's factor, and these are going to make the blood hypercoagulable, and certainly it's not a stretch to see how that might cause stroke. But we'll talk more about that in the actually coming up here very shortly.
Okay, got another NSAIDS question for you. This is from Darlin. Before COVID-19 became prevalent in the U.S., French Prime Minister recommended not using NSAIDs for fever. Dr. Seheult, can you address the use of aspirin and other NSAIDs as antiplatelets now that thrombosis issues of COVID-19 are evident?
Yeah, so that's a very important thing. We just don't know. There's two aspects, though, to this. There's coagulation, and then there is platelet adhesion. And the studies seem to indicate that there's high levels of factor 8, of von Willebrand factor. This does play into the platelet because the platelet does use these things. One of the things that you can use against von Willebrand's factors are the 3A2B, the 2B3A inhibitors, basically. So we don't know. We just don't know. I would say at this point, if somebody has to be on aspirin because they have a stent, specifically a drug-eluting stent, they should be staying on their aspirin at this point, because the COVID-19 interaction with aspirin is a big black box. We don't really know to what degree it's affected. We do know very clearly that there is a risk if people need to be on aspirin for specific reasons. If they stop them, there is also a very large risk of thrombosis if they stop aspirin and or Plavix in those situations. The same thing goes for people with strokes. So certainly at this point, I would say if you're on aspirin and Plavix from your doctor, you should stay on it. If you're a physician prescribing it, and there's a clear indication from what we know on studies that involve aspirin and Plavix, you should continue to prescribe those until we find out exactly what the risks and benefits are from COVID-19, because we simply don't know. And by the way, that's the same answer that I would give for ACE inhibitors and ARBs. We haven't had a question on that yet, but I'm sure we will. If you've been prescribed a medication that may have an effect or not with COVID-19, then you just need to continue to do that until we find out more information, because we just don't know at this point.
Okay, let's do one more question here. And this is from a viewer in Colorado. Are people with underlying conditions, including age, as likely to be asymptomatic carriers as compared to the general population?
Yeah, we haven't really done those studies yet. It seems as though a lot of young people are the asymptomatic carriers. It seems as though that's the case. It could also be very well the case in the elderly as well. We just don't know. It's certainly clear that people become more symptomatic as they get older. Certainly the mortality is that way. But what we would have to do just to find that out is to test people extensively and then review their histories and then be able to see if they have antibodies. I'm not aware of any tests that have looked at that specifically as yet, so we would have to hold off on that.
Okay, I think we can go ahead and proceed with the presentation. We'll get to some more questions soon.
Great, so this is the bulk of it, and this is what everyone wants to know is the management. Okay, so let's talk about management. And I'll just say, I'll let you know where what the official responses are, what the official recommendations, and I'll let you know where my personal opinions may differ on some of these things, or maybe go along with what they say, but maybe a little bit different based on some evidence. The labs that I think you ought to have on these patients are the CBC, the CMP, the CPK, ferritin, the PT, PTT, and the D-dimer. with a number of these other labs like LDH, troponin, ECG, hepatitis B and C, and HIV. These are important in distinguishing what these patients have for other patients that might be coming in. I think a chest x-ray is very important. I would hold off on doing CT scans unless it's absolutely necessary because of the turnaround time that we mentioned. Echocardiography is also very important, especially since the cardiovascular system is involved in this. And then blood cultures are not necessarily routinely needed to be done, but if there is need for blood cultures, then we should do that as well. When I say a need for a blood culture, I'm talking about if there's obvious fever or new fever, or there is rigors or chills. What about antibiotics? Antibiotics do not necessarily have to be prescribed. There's not routine. If you see a superinfection, then go ahead and treat, although superinfection is not very common in COVID-19. Getting a gram stain culture sensitivity is important. And if you notice that there is an infection, then using the regular IDSA guidelines are important. So if it's a community-acquired, consider using a third-generation cephalosporin and a macrolide. Or if it is a hospital-acquired, then you need to cover for MRSA, Pseudomonas, etc. We talked about NSAIDs already, trying to avoid. What about blood clots? If officially, if you go to places like UpToDate, at least currently at this point, they do recommend low molecular weight heparin for prophylaxis. That would be like Lovenox 40 milligrams subcutaneously if they've got good renal function. But there's some data that has come out that has shown that if the D-dimer is elevated, more than 1 microgram per liter, there's about an 18-fold increase in the mortality of these patients. I think that's a very, very strong signal that thrombosis is the real problem in COVID-19 and maybe the big issue, at least I'm feeling at this point. There's no recommendations for anticoagulation at those levels, at least here in the United States. I do know that the UK is advocating full anticoagulation in some of these patients. And this is what I was talking about before. Here's a paper that was published in Thrombosis Research showing severe COVID-19 infection associated with endothelial activation. This is a case where they basically took a patient that had come in during the ICU stay, and by day 21, when they checked D-dimer levels, they were as high as 21 or even higher, and that the von Willebrand factor and the factor 8 was at 5 times the level of what it normally would be in that situation. And so this sort of goes along that they say that there was endothelial damage that was causing von Willebrand's factor. You know, I'll say something that's very interesting that we are looking into as well, that there was some research a number of weeks ago or a month or so ago that showed that type O blood type had a better mortality than type A, B, or AB. Well, it's interesting to note that type O blood also has the least, generally speaking, the least level of circulating von Willebrand factor. Now, whether that's just an association or a coincidence, but I find it interesting that we're seeing high levels of von Willebrand's factor and clotting factors in this disease, which is certainly endothelial in nature. Again, angiotensin-converting enzyme 2 confers endothelium protection and attenuates atherosclerosis. Here we see that ACE2, which is what we were talking about before, makes angiotensin 1,7. And this helps the endothelium by attenuating, by suppressing NADPH oxidase. And so their conclusion was that ACE2 treatment approaches may be a novel approach to limit aberrant vascular responses and atherothrombosis. So it's a direct connection here. And if you look at the antioxidant system, you'll see here very clearly that NADPH oxidase makes this superoxide. And the superoxide dismutase reduces it back to oxygen, or oxidizes it back to oxygen, reduces it to hydrogen peroxide. Hydrogen peroxide, of course, is metabolized by the glutathione peroxidase system, which is reduced by things like, you know, N-acetylcysteine, which is being used, and et cetera. So this system is plugged into, if you will, the ACE2 and the angiotensin 1,7 system. So I think that's really important. Here's another study that showed that oxidative stress, and it says here, there's evidence for the critical role of NADPH oxidase derived oxidative stress in atherosclerosis has come from both cell culture studies and animal models. NADPH oxidase and superoxide, those species that we were just talking about, is increased in vascular cells by a variety of agonists. One of those is, guess what? Angiotensin II. And so if you knock out ACE2, like we were talking about before, if you knock out ACE2, this one right here, which is responsible for metabolizing angiotensin II, then instead of you metabolizing it to angiotensin 1,7, which is a vasodilator, it's going to be going down this pathway. It's not going to be taken out by angiotensin II. It's going to allow the virus to bind. The virus is going to take out your ACE2, and angiotensin II is going to bind to its receptor and cause all of this oxidative stress, angioedema, vascular edema, I should say, increased blood pressure, vascular permeability, and all of those sorts of things. So what's the bottom line there in terms of anticoagulation? I think there may be a benefit to anticoagulation. We just don't know specifically. And that's why these organizations really can't say for sure, because we haven't done the studies yet. But it's certainly looking like this is an area or a target of therapeutics. All right, what about oral, what about nebulizers? We don't want to spread the germs. What about steroids? You know, they say that you shouldn't start steroids just for COVID-19, and that could be associated with increased mortality because of it was an influenza, or there could be decreased viral clearance because they saw that in MERS-CoV as well. We talked about ACE and ARBs. You can see that very clearly. It would seem to say that if we could somehow reduce angiotensin II by putting somebody on an ACE inhibitor, or block angiotensin receptor blocker by putting them, angiotensin receptor by putting them on an angiotensin receptor blocker, that would help. We just haven't done those studies, so we don't know for sure. I would say that if you're on them, I wouldn't stop them. If you're not on them, I wouldn't go and put yourself on them because there are other potential side effects of that. So take it by a case-by-case basis. All right, so let's talk about some individual medications. So remdesivir, big in the news yesterday and the day before. It's a medication that's been around. It's been tested. It's relatively safe. It just hasn't had an FDA approval because it hasn't worked in anything up to this point. They tried it in Ebola and it didn't work. What it does is it stops transcription. It stops that replicase that we were talking about at the very beginning of this webinar. Well, yesterday there were two officially published news articles. One of them was actually a paper in The Lancet, and that showed, that was a study out of China that really didn't show any benefit to remdesivir. There were a couple of criticisms of that study. Number one was that it never reached its full conclusion. They weren't able to fill the study because the epidemic in China had gone away by the time it was in full swing. The other one is that they could enroll patients in that study up to 12 days after they became infected. And we know with studies here in the United States and around the world that Tamiflu, you need to be on Tamiflu within the first 12 to 24 hours. So that was a negative study, unclear exactly what to say about remdesivir. The other study was an interesting study. That's a study that's done here in the United States. They originally enrolled over 1,000, or that was the goal. But with these studies, what they do is they look at them and they see whether or not their endpoints have been made. And the two endpoints that were important in that study was time to improvement and also mortality. So when they did the interim evaluation of the study, they found that those endpoints had been met and that it was unethical to continue the study and give placebo to patients when they knew that this was making a difference. So they stopped the study, and now they're working on trying to get an emergency use application from the FDA, and they're talking with the maker of remdesivir, which is Gilead. By the way, I have no stock or anything in Gilead, no interest, no financial interest, as we mentioned. So they're looking to see whether or not Gilead can ramp up production potentially and get this out there. Now, I want to make it clear, this is not a cure. When you look at the mortality differences in the placebo group, it was 11.6%, and in the treatment group, it was 8.0%. That's a drop of 3.6%. If you do the number needed to treat on that, which is 1 over the absolute risk reduction, you get 28. What does that mean? That means that you would have to treat 28 patients with COVID-19 to save 1% person's life. Of course, it's worth doing, but you can see it's not like a parachute for somebody falling out of a plane where you just need to treat one person to save their life. You got to treat 28. So it kind of gives you a magnitude of the effect of remdesivir. All right, real quickly, let's talk about hydroxychloroquine. A lot of questions about the mechanism of hydroxychloroquine. Does it raise the pH of the lysosomes? Does it prevent binding of the virus? Is it a zinc ionophore? A lot of proposed mechanisms could work by any one of those at this point. It's been a political football, unfortunately, and right now we still don't have a randomized placebo-controlled trial that tells us. What I'd like to do is just quickly go over a video that we did on MedCram where we discuss about the different studies and why we are where we are right now.
Brings us to hydroxychloroquine. People have been asking me about the newest study in hydroxychloroquine. So let's take a look at all of this. And this is a VA study. It's a retrospective study. But before we get to this, let's kind of look at the history of the studies on hydroxychloroquine. So this is a really good article from goodrx.com, which I'll put a link to. And it does a really good job of summarizing all of the different data points that we've come across for hydroxychloroquine. And the question is what do research studies say about hydroxychloroquine, chloroquine, and COVID-19? Of course, we know that data is limited, but let's go through all of the positive studies for hydroxychloroquine, and then we'll go through the negative studies. So this kind of started back in mid-March, where there was a report that showed that over 100 people with COVID-19 had been treated with chloroquine, and that their disease was shorter in illness duration compared to those that didn't. But we actually never got the data on this. Then, of course, we all remember study number 2, which was March 20th, 2020, and that was that small study in France. And it showed that people who got hydroxychloroquine had a viral load that was much lower than the comparison. The problem was that the comparisons were between different hospitals. The other problem was that the people who got hydroxychloroquine, 23% of them had to stop, and so they weren't included in that analysis. Also, 6 people received azithromycin, which is not even an antiviral, it's an antibiotic, and they got that with the hydroxychloroquine. And that combination led to even lower viral loads. So part of the problem when you combine hydroxychloroquine and azithromycin is something called QTc prolongation. This is basically the time it takes between contraction of the ventricle and full relaxation of the ventricle. And if that takes too much time, you can get arrhythmias to occur. Then there was a study at the end of March that came out of Wuhan, China, that looked at cough and fever, which had improved about 1 day earlier for those that got 400 milligrams of hydroxychloroquine for 5 days compared to those who didn't get any. Additionally, pneumonia improved in 25 of 31 patients who received hydroxychloroquine to 17 of 31 who didn't. Okay, so now let's look at some of the negative studies. In this study, they looked to see which group kicked the virus faster. And 30 people were given either placebo or hydroxychloroquine for 5 days. And in the placebo group, 93% tested negative versus 87% of people who received hydroxychloroquine tested negative after 5 days. Basically, it was a wash. Then there was a French study which tried to duplicate what had been done in their country prior with azithromycin and hydroxychloroquine. But here, after 6 days, 8 of 10 patients were still positive for SARS-CoV-2. 1 person even died. But again, this study didn't have a control group either. Here again, they're looking at 150 patients to see which one kicks the virus faster. This time they got 1,200 milligrams for 3 days, then 800 milligrams for 2 to 3 weeks, or not. And at the end of the study, 85% of the patients who got hydroxychloroquine tested negative, versus 81% who didn't get the medication or got placebo. So pretty much these different groups behaved about the same regardless of whether or not they got the medication or not. Okay, and now we come to this study, the study that we're looking at today, which was the VA study. Now the first thing you got to realize is that this is a retrospective study. So this is not the highest level of evidence that you can get. But it's a fairly large study, 368 male veterans. All of them over the age of 65. So once again, it may not be generalizable. But, disturbingly, the death rates were the highest in the group that actually received the hydroxychloroquine and then the next highest in those that got the hydroxychloroquine and the azithromycin, whereas the group that did not receive hydroxychloroquine had the lowest death rate. And this was actually statistically significant.
So the thing that's really interesting about that whole article was that, yeah, the patients that had the hydroxychloroquine had a higher mortality rate. But those two groups were really different from each other. One of them was a lot sicker than the other. And so the question is those people that died, more likely to die, that group that was more likely to die, was it because they were on hydroxychloroquine, or was it and they were on hydroxychloroquine? The same thing what we talked about at the beginning with, in the JAMA article, with patients who were admitted to the hospital and placed on ventilators. They had a much higher mortality rate. Was it because the ventilators were killing them, or was it because they were dying and they were on the ventilator? And that's the problem with retrospective data, is you can't tell that difference, which is why we need to have a prospective study. The other thing that people are doing are convalescent plasma. So these are patients that have already come down with COVID-19. They've recovered, they've gotten antibodies, they donate those antibodies, and we give those antibodies to other people who have not recovered. There's only a few ways you can get this right now in the United States, and hopefully also around the world. Clinical trials is one way. There's something called an expanded access program, where you or your hospital can be plugged into getting that. At least in the United States, you can apply to the FDA, and I've done this before. You write an email to them through their site, and they will give you emergency access so that you can get a number, and your blood bank, who's hopefully collecting the plasma, can then give it to your patient. We don't have a randomized controlled trial on that at this point. There's tocilizumab, which is an anti-IL-6, which is implemented in the STORM. Again, we don't have any randomized controlled trials on that. There's others, right? There's favipiravir, I always say this wrong, favipiravir, an RNase polymerase inhibitor. There's interferon beta. There's lopinavir, ritonavir. And all of these, really, we don't have any randomized controlled trials on at this point. WHO is also doing some randomized controlled trials as well at this point. The only one that we have a randomized controlled trial on is actually remdesivir. What about hospitalization? So I've got some factors here that tell you whether or not the patient should be hospitalized. Hypoxemia, respiratory rate, more than 50% of the lung involved, high CRP, and you can see the rest of the labs there. All of these are predictors that the patient should be admitted to the hospital. People that don't need to be hospitalized, fever, malaise, cough, no shortness of breath. Up to date says that they say, quote, we generally do not treat patients with non-severe disease with experimental agents outside of the context of a clinical trial. But, you know, as we've talked about before, there's a lot of people in that phase 2. There's millions potentially. These are people that don't even know they have COVID-19 perhaps, or they have it and they're just sitting at home waiting to get worse. What do we do for these people? So there's a lot of things that are being looked at. Vitamin D, we've got good evidence just most recently out of Ireland that shows that vitamin D supplementation in those that need it can cut chest infections by 50%. Vitamin C has some retrospective data with ARDS and also with sepsis. Quercetin in Ebola, zinc, we know in vitro inhibits coronavirus. We also know that zinc helps in vivo as well for other viruses. There's the BCG vaccine that we talked about. There's the vaccine itself that we're looking at, N-acetylcysteine, which is a antioxidant for the glutathione peroxidase system that we talked about before. There's even a trial looking at famotidine in very high intravenous doses. We've talked about before on MedCram about hydrothermal therapy. This is what they used to do 100 years ago before we had trials. And we know there's good evidence looking at elevated fever can help. They did this before with neurosyphilis, and by giving patients malaria to treat the neurosyphilis and then treating the malaria. So there's a lot of good data from many, many years ago. They're looking at doing natural killer cells from placental mesenchymal cells and infusing those. We know that sleep is very important. We could talk about that for another hour if we needed to. And then finally, nutrition, because what we're noticing in these patients is that the patients that are being admitted to the hospital, they are very rich on cardiovascular disease, BMI, hypertension, very low on COPD and asthma. This was actually surprising because we thought these were the people, the COPD and the asthma patients, that were going to be ending up in the hospital. It's not. It's the more oxidative stress, endothelial, cardiovascular stress type patients. And again here, so here's the paradigm. Oxidative stress moves you to the left. And what you see here on the left is the result of high carbohydrates, glucose, fructose, high saturated fat, oxidative stress things. But moving to the right are the things that we see associated with whole grains, fruits, vegetables, etc. These are the things that are nutrients for the endothelial cells. And it could be, a multiple hit model here where these people that are on the left-hand side with a lot of oxidative stress, and now they're getting the coronavirus, which tips them over the edge. And that's why we're seeing people with cardiovascular disease and large BMIs getting into the hospital as opposed to people with lung disease. Again, more evidence that this may be a more complicated disease than we actually thought. So in summary, working hypotheses, patterns are emerging in the hospitalization of COVID-19. Prognosis is poor for severe patients at this time. There is one positive randomized controlled trial, remdesivir, and that looks promising. It's another tool in the toolbox. It's not a cure. There's many interesting leads which need to be looked at, not the least of which is the endothelial situation in the vasculature. And of course, we're going to need more randomized controlled trials to know for sure. We need to look at thrombosis and, of course, nutrition. And with that, I think we'll open it up to any kind of questions, Kyle, at this point.
Well, thanks, Roger. I'm going to summarize a few questions that I've seen multiple times on our YouTube live stream. And the first one, a lot of people are wondering about Kawasaki's disease and the reports of, especially children in Europe getting Kawasaki's disease. Could you talk a little bit about that?
Yeah, so Kawasaki's disease is essentially a vasculitis. And that is what we are basically talking about when we're talking about oxidative stress on the endothelium. We're talking about, if you noticed on that article where they wrote in on thrombosis, not only did they find elevated levels of factor VIII and von Willebrand's factor, but they also found elevated levels of anticardiolipin antibody and anti-beta-lipin antibodies as well. When you are ripping through endothelial cells, you are exposing parts of the vasculature that should not be exposed, and your immune system is going to make antibodies against it. And depending on what's exposed, you can imagine there's going to be different antibodies. It's certainly possible that, it's certainly conceivable that in some patients, when you have endothelial dysfunction and you expose parts of the vasculature to your immune system, you're going to get antibodies against various things. Kawasaki's is simply an antibody against some of those things. And so it's not too surprising if that is what is going on. And we don't know for sure, but if that's what's going on, that is what we might see.
Quite a few viewers are wondering about quercetin, and you've talked about how one of the possible mechanisms for how hydroxychloroquine could work in fighting COVID-19 is through a zinc ionophore. And, we believe that quercetin is also potentially a zinc ionophore. Do you think there's value in doing trials on quercetin? Do you know of any trials on quercetin at the moment?
Excellent question, Kyle. So this is the thing, is there are studies that show that hydroxychloroquine acts as a zinc ionophore. No question about it. There are studies that show that zinc inhibits coronavirus replicase. No question about it. There are studies that show that quercetin is a zinc ionophore. No question about it. There are studies that show that quercetin may be beneficial in coronavirus. It has been proven or been shown to be beneficial in Ebola. So those are all dots. If we connect those dots, we come up with a line, and that line may be true, the line might not be true. So is it possible that if hydroxychloroquine is a zinc ionophore and quercetin is a zinc ionophore, that quercetin might work? The answer is yes, it's possible. It's even possible that quercetin is a zinc ionophore and it does it in a completely different way. We don't know for sure because all these tests have been done in vitro. And unfortunately, when you do something in vitro, you're controlling all of the variables except for that one variable. However, when you put that into a system, into a human being, into an animal, etc., now it's playing back and forth with it's a very complex system. And so we really don't know the answer to that. They are studying quercetin. However, there's a Dr. Dr. Quercetin in Canada and another Chinese physician are both supposed to be conducting randomized controlled trials in China on quercetin, and so maybe we'll know the answer when they get done with their work.
Okay. I'm going to summarize another group of questions that have come in about anticoagulants and the risk of myocardial infarction, the risk of stroke, the risk of pulmonary embolism with COVID-19. So for a patient that gets hospitalized, at this time, what we know now, would you put them on anticoagulants prophylactically? And if so, what would be one of your first choices to do that?
Yeah, so what I'm doing right now is I'm looking at the D-dimer levels, and if the D-dimer levels are, depending on the scale in your hospital, greater than 1 or greater than 1,000, depending on whether you're using nanograms or micrograms, deciliter per liter. Anyhow, I think the current recommendations of what they're looking at least out of the UK, is to put them on some sort of anticoagulation if there is no contraindication. I say that slowly because I don't want to think that everybody needs to go on anticoagulation. There's a risk in thinning everybody's blood, of course. So you need to look at the risks versus the benefits. From the evidence that I have seen, or at least not the evidence, but the expert opinion, heparin drips are being used, although the issue with heparin drip is that you do have to titrate it. The nice thing is if there is a bleeding problem, you can always turn it off fairly quickly. We are currently using low molecular weight heparin in our patients who we believe deserve to have anticoagulation. Most of the patients that we're seeing that are sick enough to be in the hospital have D-dimers well over 1.0. And so that is currently what we are doing. We don't have any evidence for this. It just seems reasonable that if we're seeing that their D-dimers are high and this could be a coagulation issue, it's reasonable to put them on a blood thinner if there's no danger of them bleeding.
And just to follow up on that, Clara from Michigan had a specific question along those lines. She said she had a patient with COVID-19 that had a stroke, that had an acute CVA, and is on Xarelto currently. How long should she anticoagulate for?
Well, that's an excellent question. So I'm assuming she was placed on Xarelto after she had these strokes, not before it. That's an excellent question. And you know, it's an interesting thing because I remember hearing early in this course about patients who were recovering in the hospital and then going home only to come back very quickly and die. And it's like, well, what is going on here? If this is just an ARDS picture, we don't see that in ARDS patients. So that makes me think even more that this is an endothelial dysfunction, because when patients present to the hospital and they have a blood clot, and that blood clot is due to something that we know. In other words, it's a provoked blood clot. For instance, they were in a car for too long, or they were on a plane for too long. And we're able to remove that provoking factor, so they're not going to be on a plane. In this case, it would be that they're no longer infected with coronavirus. The minimum recommended time for anticoagulation is 3 months. So I would say at this point, if it turns out that COVID-19 is a hypercoagulable state, and the patient has developed a clot, and we believe that their clotting factors will go back to normal after the infection goes away, and all of those are ifs, then I would recommend at least, it would seem logical that at the very least these patients should be on blood thinners for 3 months. That's just an expert opinion. That we call that grade D evidence. That's expert opinion.
Got it. Okay, one more question, Roger.
Oh, we can go as long as we need to go.
Okay. So this is a clinician from Ohio that is wondering how to counsel patients, aside from promoting good, balanced nutrition, quality sleep, exercise, maintaining a healthy weight. What else do you think the evidence is good enough at this point to recommend? And is there any reason to discourage these patients from supplementing with vitamin D, vitamin C, and zinc in relatively low doses?
Yeah, so long as those doses are relatively safe, there's no reason. Right now, because of the lack of randomized controlled trials, we just have one at this point, and we're not even able to get that medication. So essentially, we've got nothing. Right now, everything's got to be benefit versus risk. I'll tell you what I do. So I do take zinc. I do take vitamin C. I do take vitamin D. We made a video about it, Kyle. The other thing that I do, there's some evidence that that heat followed by cold can be beneficial. If you look at the Finnish data, they take saunas. They have 50% less respiratory infections when you look at an associative study that was published a number of years ago. So hot, cold showers, all sorts of things. At this point, you know, it may work, it may not work. I'd rather be on the side of doing something that didn't work than not doing something that could have worked.
Excellent. And Roger, remind me, is there more to your presentation, or are we purely in the question and answer?
We are purely in the question and answer period.
Okay, excellent. So just so the viewers out there that have hung with us this long know, we're going to go for at least another 20 minutes. And again, we apologize for the difficulties at the beginning, but we're going to keep the question and answer going. And the next we've seen a lot of questions come in about antibodies and about immunity. And I know there's a lot we don't know at this point. But based on what we do know, or what you know about coronaviruses, Roger, what's your feeling about the ability of this SARS-CoV-2 virus to mutate relative to something, you know, we're all familiar with, like influenza?
Yeah, so it's certainly possible, right? How many times a year do we get a cold? We get it often, and this is coming out of the family of cold viruses. So that being said, there was a study that was done, Kyle, where they looked at monkeys, and they infected these monkeys once with a particular strain of the coronavirus, and then they tried to do it again, and they couldn't do it. And that tells us that, yes, so long as the virus doesn't mutate too dramatically, then we should be able to have immunity to it. That's no surprise. The question is about mutation. Generally speaking, mutations should affect the entire genome equally. Generally speaking, that's what we should expect. But you've got to realize that if there's a mutation in the spike protein, the very protein that is essential for the virus to infect a human, that virus is never going to get into that human because of the mutation. So we don't expect highly conserved areas of the virus to mutate, because that's how they get in to the patient. And so if we form antibodies against that portion of the virus, it stands to reason logically that that immunization should be good, at least for a period of time, so long as the body can make those antibodies. But we don't know until we actually get the virus and get the vaccine out there.
And then along those lines, I've seen a few questions come in about MERS and SARS, and people that have had those particular infections. Do we have any reason to believe they might have immunity or a less severe course of COVID-19?
Yeah, it's possible, although the amount of people that we're talking about is minuscule compared to the number of SARS-CoV-2 patients. But yes, the SARS-1 virus, or just the SARS virus as we call it, had the same receptor, the ACE2 receptor, as its target. And so it's very possible that if antibodies were formed against SARS, that those antibodies, 10 years later may be effective against SARS-CoV-2. But it's, you and I both know, and me as a medical doctor used to be a medical student, and we used to have our titers checked. I remember I got immunized against hepatitis B as part of my medical school matriculation. And years later, when I had my hepatitis B titers checked, they were negative. So I had to get a booster. And so it's possible, the SARS was 10 years ago or more, 20 years ago, actually. And so it's certainly possible that those antibodies have burned out.
Excellent. What about ivermectin? A lot of folks have written comments about ivermectin. Did that just kind of fall off the map, or
no? I should have probably included it in the presentation. So ivermectin is an anti-parasite medication. We usually give it once to patients that come into the hospital. It's a fairly benign medication. What it does is it prevents the transport of viral proteins into the nucleus. So there's a nuclear transport mechanism that transports things from the cytoplasm into the nucleus of the host cell. And the virus uses that transport mechanism to transport its proteins into the nucleus to prevent the cell from replication, from doing various different things. If that's an immune cell, there's certainly going to be problems with immunity. What ivermectin does is it shuts that transport system down temporarily and prevents the virus from suppressing the immune system. At least that's what it's felt to do at this point. You can give somebody ivermectin, and it usually lasts for about a week. We usually dose it another week later if that's what we need to do. But very little side effects. I'll tell you, the patients that I'm seeing in the hospital, they're getting hydroxychloroquine, they're getting zinc, they're getting high-dose vitamin C, they're getting ivermectin, they're getting, if they have a high D dimer, they're getting Lovenox. They're still very sick. They're not like dramatically improving the next day. I have not given any of my patients remdesivir because I haven't had it available. It's very difficult to get. The only way you can get it right now is on a compassionate use for people who are pregnant or for pediatrics. Right now, if you're not pregnant and you're an adult, the only way you can get it is through a trial or wait for the FDA to get that emergency use that we were talking about.
So I'm seeing a lot of questions come in about nitric oxide. Do you have any information on that to share?
So nitric oxide is basically a way of dilating the vasculature. And so angiotensin II, as we talked about, is a vasoconstrictor. It constricts the pulmonary vessels, potentially. It could also cause thrombosis. So if that angiotensin II is constricting the blood vessels in the lungs, particularly by alveoli that are ventilating well, it would be very beneficial for oxygenation purposes to dilate those pulmonary arteries, pulmonary arterioles, capillaries, that are next to the alveoli to allow more blood to flow by ventilated alveoli. Well, if you're breathing in nitric oxide, you know that that nitric oxide is going to go to well-ventilated alveoli. And so they're actually proposing a study to look at this to see if they could even get patients not only to have better oxygenation, but to send them home. The trick is in getting a device that they can take home with them and to getting a medication that is long-lasting enough so that the patient doesn't have to do it more than 4 times, 5 times a day. But yeah, that's a very interesting and promising looking study that may be beneficial.
Danny from Rhode Island has a practical question, wants to know, why do you think we're calling it social distancing? Should we, as a nation, as a world, be calling it physical distancing?
Yeah, that's an excellent question. And you know what? I didn't even think about it until someone had brought that up. They called it social distancing, and so I called it social distancing. But then when it was brought up to me, actually it was you, Kyle, that brought that up to me and made me think about that. We shouldn't be socially distancing ourselves. We should be socially connecting ourselves at this point. The real key, see, the virus doesn't spread by social connectivity. It's by physical. And so we should be doing physical distancing. But what we're doing right now with you there in Rhode Island and with the people in Australia and the UK and India is we're getting together, and it's fun to do that. And I'm glad that we're here. So we should not socially distance our audience. No.
Okay. So a lot of questions coming in about, and I know, Roger, you did a video earlier on in our COVID-19 updates about how many mutations have already been observed in SARS-CoV-2, and we hope relatively minor mutations. Of course, there's some speculation that maybe places like New York, places like New Orleans that have had a really have had a significant outbreak may have a more severe strain than other parts of the country. Can you talk a little bit about, in the context of a vaccine, which we're all hoping we have, maybe the difference between minor mutations that a vaccine or a previous infection would work for versus a large-scale mutation that's big enough to actually render a previous infection or a vaccine not effective?
Yeah, that's a real concern, Kyle. That is a real concern because we've seen that. We see that all the time with influenza, which is a different virus. It is an RNA virus, but it looks at a completely different receptor. And so you can have shifts and you can have minor tweaks. And depending on what you get, it's going to be a completely different type of infection, right? H1N1, 2009, swine flu, that was a major epidemic. Could you see something that way with SARS? Yeah, could SARS join our cadre of seasonal viral infections? It's certainly possible. And would a vaccine help? Yeah, we could be dealing with the same thing that we're dealing with the influenza. We're always looking ahead to Australia to see what kind of infections are going on there and try to get it predicted correctly here. So it's certainly possible. That is not outside of the realm of reality. The website, I think that's very good on that, is NextStrain, which tracks this coronavirus and all the different viral strains. There's some feeling that the New York strain was obtained from Europe, and that the California strain or the West Coast strain was gotten by directly from Asia because of travel patterns, of course. You know, whether or not one gives you immunity to the other still remains to be seen. I think it'll be interesting to see if that's the case.
Okay. I'm seeing a lot of questions about trials and where do we stand, and kind of taking a step back and looking at the big picture. What are the next steps in combating COVID-19? So this is, I'm putting you on the spot here, Roger. If you had a grant for a significant amount of money and you could design a study, a trial, however you wanted to, with whatever medications or supplements you wanted to, what would be one that would, you know, kind of rise to the top, that you could initiate down there in Southern California, for example?
Well, this is more of a philosophical question, because I'm sure that there is a perfect anticoagulant probably out there somewhere that we could use, and it would be great to try that. It would also be great to find out how we could eliminate some of this endovascular problems. I think that would be a great trial. Ivermectin looks like a great trial. All of these trials look good. Hydroxychloroquine would be great to have but they're all being done at this point. And eventually they're all going to come out. But the question really remains is what I was talking about before, which is phase 2. The real issue here is that by the time you have, the farther down the course of the disease you go, okay, hospitalization, intensive care, the less you're able to actually change on this patient. That makes sense, right? Because there's been more time for the virus to do what it needs to do, whatever it's doing. But there's also less people to treat. And so it's easier to make enough of a medication to treat that many people. What I would like to see, what I think would be amazing, is to find out further up the course, is there something that we can do to reduce the progression in those early days of the infection? Something that's very simple, something that doesn't require a drug to be manufactured, for instance, something that doesn't require a distribution or logistics to get out. All it takes is information and understanding. And if there's something that we could do at that time, whether it be, you know, dietary things like you talked about, nutrition, whether it be what we saw maybe 100 years ago in these sanitariums that we talked about, if we actually knew what the effect of that was and we implemented public health strategies, that could be very helpful in preventing a lot of hospitalizations. And if we were able to mitigate that, if it worked, it would be able for us to open up society potentially and to be less restrictive, because we wouldn't be worried about flattening the curve and having that bar so low. So I think from a public policy point, if I had unlimited source of resources, it would be, instead of focusing my energy on phase 3, which is hospitalization, I would love to know the things that would really work in phase 2 that could bring down the progression of this disease. In other words, if 80% are getting better and don't need hospitalization, what is it about that 80%? Let's make it 90% or even 95%. That would, to me, be the biggest win that we could have.
Okay, back to a testing question here, Roger. If someone's had a positive COVID-19 test, the PCR test for acute infection, they've recovered, they're no longer showing symptoms, are they okay to go back to work? And if so, how long should they wait before going back to work, whether it's in healthcare or some other industry?
So I think you've got to understand that those negative PCR tests are potentially, depending on which one is done, plagued with false negatives. So depending on how critical the job is, for instance, if you're a healthcare provider, are you going to depend on one negative test? You know, some would say, no, you want two. If you're a nursing home and you are accepting a patient back to your nursing home, do you just want one negative test or do you want two? So this is what we're talking about here, is it really depends on how critical is it that the patient really be negative. If you're just going back to your home and you're just going to stay in your home anyway, maybe one negative test is fine. And that's why I think you're seeing differences in terms of the situation about how many tests are required here, how many days being symptom-free here. It's being tailored based on the clinical situation. So if it's a very critical period where you could potentially be a super spreader, we're going to really want to make sure, like if you're a healthcare worker and you could spread it to a lot of people who are immunocompromised, you're going to really want to make sure that these patients are protected and that that person in particular really is negative for coronavirus.
Mm-hmm. Okay, a question from Mary Lou in Scottsdale, Arizona. And Roger, you talked about this in some of your previous videos, but we know that the rate of infection and the severity of COVID-19 is lower in children. Actually, I take that back. I don't know if the rate of infection is lower, but we know the severity overall is lower in children. How do you make sense of that?
Well, one of the proposals that has been put out is the innate immunity. So the innate immunity, that wing of the immune system, which basically goes around and just eats things up and then presents it to the adaptive immunity, is very strong in young people. And it gets generally weaker and weaker as you get older and older. And so any way that an adult can strengthen their innate immune system is something that is worthwhile doing. There's a number of things out there that we've shown that can do that. Just there's been some studies that show that by increasing the temperature, sitting in a hot bath for a period of time to raise the temperature, they took monocytes out of people who had done that, subjects who had tested that. And those monocytes were more plentiful and actually had a more effective response against lipopolysaccharide, which is a bacterial chemotaxid. So we know that fever is the body's innate immune response, right? And we know that kids, when they get a viral infection, almost all of them get fevers. Look at the study that we just showed there in JAMA. What percent of patients with COVID-19 came into the hospital with the fever? 30%. 30%. When I went to the hospital today, there was someone standing at the door that was checking to see who was coming in, and they were doing these scans on your head to see what the temperature was. Just realize that 70% of the patients that ended up at the hospital with COVID-19 did not have a fever. And so that is part and parcel of the innate immune system getting worse as you get older.
Mm-hmm. Okay, a question about aspirin. And we've talked about anticoagulation. We've talked about risk of emboli and myocardial infarction and a stroke. Do you think there's any compelling reason to take low-dose aspirin, even for an adult that's, not over 65 years old in the setting of a pandemic like this?
The concern that I have is that taking low-dose aspirin may impair your body's ability to mount a fever. The other aspect of this is that aspirin predominantly affects the platelets, okay? Whereas in COVID-19, a lot of the negative factors are mitigated by hypercoagulation, so actually coagulation factors. Of course, albeit that von Willebrand's is involved with platelets and coagulation, it's kind of that bridge between the both. We just don't know. And I'd hate for people to be put on low-dose aspirin. I mean, there's a lot of risks in putting a lot of people on low-dose aspirin when it comes to ulcers in the stomach and inhibiting your platelets, also inhibiting fever as well. Mm-hmm. So this is, I think, a discussion that you have to have with your physician.
What about hyperbaric oxygen? You've explained today and in your updates about how this hypoxemia can be a result of, or can occur in patients with good lung compliance. Do you think hyperbaric oxygen is something worth trying? Do you know of anyone that's currently studying that?
So hyperbaric oxygen is a way of, if you go to 100% oxygen on the ventilator, that's 760 millimeters of mercury. That's as high as you can go. You can't go any higher than that, especially, and that's at sea level, right? So hyperbaric oxygen, if you go to 2.5 atmospheres, that allows you to get a tremendous amount of oxygen through the barrier, through the alveolar barrier and into the blood. The problem is that to get somebody, there's different types of hyperbaric chambers. There's ones that you can literally walk into. Those are very rare. Mostly what you see is these little cylindrical tubes that you fit very closely in. And while it is possible to get people in there on ventilators, it's very difficult to do that. And there's probably just not enough of those. Theoretically, I imagine it might help with the oxygenation issue. But there's a whole bunch of other issues that get brought up when you're dealing with hyperbaric oxygen, not the least of which is that a lot of these patients are unstable. They're on vasopressors. These are medications that are used to increase their blood pressure. And if something were to happen to that patient in the tube, you've got to wait a particular period of time, maybe 20, 30 minutes in some cases, to bring that pressure down slowly. Otherwise, you could have what they call the bends, right? You could have micro bubbles that could cause embolization and make the situation worse. So it's difficult. It's a difficult situation to do. I think probably a more practical way of doing it is ECMO, which is where you actually just bypass the heart and the lungs. That also is difficult because of the limited amount of ECMO. ECMO is not without its drawbacks. It can cause mini strokes and things of that nature. So depending on if things embolize. So it's not risk-free at this point, but it's certainly something that has been done, ECMO that is.
Okay. Another question about recovering from COVID-19. And of course, at this point, we have a lot of patients that have had COVID-19 and have been given the title recovered. So a two-part question. How much do we know about how the definition of a recovered patient in different countries all over the world? Is there standardization to that? And in a future pandemic, hopefully we never have one, but if we do, should there be more leadership about getting a good definition that each country is following so that we're consistent with that? So I'll start with that question and have a follow-up after.
Yeah, so there isn't a definite definition of what, quote, recovered means. Generally, it usually involves a negative test. It usually involves being symptom-free for some period of time, but all of those things differ. So is it one test? Is it two tests? Is it 2 weeks? Is it 10 days? All of those things are different. In these diseases that we study, when we have time to do it, for instance, ARDS, we had a Berlin conference, and they had the Berlin criteria where the whole world gets together and says, okay, we're going to study this disease, and here are the definitions of the disease that we're going to have. We never had time to do that. Part of the problem with COVID-19 is that you couldn't travel. So that was the last thing that they were able to do. I don't know of any international conference that has happened other than what the WHO is doing in terms of standardizing what does it mean to be recovered. They may have those definitions, but I know politically, because countries want to manipulate numbers potentially, they may change the definition of what it means to be a case, to be a suspected case, to be a recovered case, to make their numbers look better or the same. But certainly at this point, we're not there as yet.
Okay. And along those lines, a lot of viewers are asking about the sequelae of COVID-19. If someone gets COVID-19 and they're no longer symptomatic, what do we know? And is enough being done to study the sequelae in these recovered patients from COVID-19?
Yeah, so that's a very good question. People who have strokes, people who might have had fibrosis in the lungs. I know there's a study that's looking at N-acetylcysteine with recurrent fibrosis as a result of the infection. About this whole thing about oxidative damage and following those patients. I think it's a great question. Right now, I think we're trying to get our head wrapped around how to get out of the epidemic. People will be looking at this. There's no question about it.
I think we're about at our time for the live stream. Any parting words, Roger?
Yeah, I just wanted to thank everybody around the world for joining us. I know that there's people in all over the world, and I want to know that we really appreciate all of the comments that we get. Kyle and I read all of the comments, and we can't respond to all of them, but we really appreciate it. As I was telling Kyle a number of days ago, really a lot of the ideas that we get in order what to follow come from a lot of the comments that you guys give. So we really appreciate this. We don't feel in any way that learning is going here in one direction, because it's definitely going in two directions. And I really appreciate the fact that you have all stayed on and listened and watched. And I really want to thank also Continuing Education Company for hosting this. This is a work in progress, but they scrambled. They did a great job based on the barriers that were kind of thrown in the way here at the last minute. And so it takes a lot to sort of knock us down, but we're here and we're on the net, and we're thank you that you're all joining us.
Well, thank you very much, Roger and Kyle. I do have a couple of questions for the two of you. So you've been putting up these excellent MedCram COVID-19 updates on a regular basis. How long do you think you're going to continue? When do you say, all right, it's time to stop?
That's a great question. Kyle says, are you up for another video, Roger? I said, sure. Walter and Kyle both, I'm in the thick of COVID-19. I've saw patients this morning, and I'm currently still seeing patients in the hospital for this. I find for myself personally that if I have to learn something, I want to learn it as if I'm going to be teaching it. And so this has forced me, these videos every night has forced me to stay on top of a situation that is they say this all the time, it's very fluid. It's emerging, it's evolving all the time. And I think doing these videos have actually made me a better physician in treating these patients. And Kyle, I don't know, I can speak for myself. How about yourself?
Well, we're not too far away from 100 updates, so I think that'd be a good goal. But hopefully the pandemic is behind us by then, and we don't need to go that far. But
great.
Yeah, no, it's been great working with you, Dr. Seheult, and I hope to continue these updates as long as we need to.
Yeah. So we know that we had some technical issues early on when we started. We started a little bit late. I want everyone to know who is watching that we plan on getting these videos up, or an actual video of it without the technical problems cleaned up, and we'll send it over to MedCram so they could post it for their viewers, and it'll be on the continuing education website, cmemeeting.org as well, and we hope to get that actually tonight. In addition, Kyle and Roger, I'd like to give you an opportunity to say a few words, if you don't mind, about some of the other videos that you've just released that are somewhat related to COVID.
Dr. Seheult was one of my instructors during my physician assistant training at Loma Linda University. And the first lecture I got to see Dr. Seheult give was medical acid base. So that's a topic that totally confused me. And that's one we have on our website that I really appreciate. The other one that I love, personal favorite, is the ECG interpretation explained clearly. We have a lot of other topics: vasopressors, DKA, acute renal failure.